Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome everybody for this very unique session about glaucoma. We are together on the glaucoma platform with you all to learn from our professor Ahmed Mustafa from Egypt. He is a great professor, a great teacher, and he always takes care of young ophthalmologists like me. So I'm very happy today to moderate the session with him. And today we are going to learn from him the tube shunt surgery. And by the way, the next Wednesday, he will be as well the speaker as a continuation to this subject, but the complications of the shunts. So this lecture can be considered as two parts. Part number one today, the tube shunt surgery, and next Wednesday, the complications. The platform is yours, Professor Ahmed, and we are all yours.
Dr. Mazen, thank you very much. It's definitely my great pleasure to be with you. I always feel I have special feelings towards the activities you are creating. And one of this is the Glaucoma Sinjab Academy, or Sinjab Glaucoma Academy. So it seems away from the refractive field, you have the ability to contribute to any of the ophthalmic fields, actually. So thank you very much for the kind invitation. And I hope that the lecture will be of help, inshallah, to all of us. Yes, and now my talk will be on the glaucoma drainage devices, which is not an easy topic to cover. So I will try to cover in two parts, as you have mentioned. The part one, that's the basics, and part two, some complex cases and complications, which I think is an integral part of the work. Now, this was my patient 25 years ago. And you can see the very ugly valve. This was a valve, and it's a very encysted valve, and it's very near to the limbus, as you can see. And also you can see the cornea is opaque. Otherwise, I wouldn't have put this tube in the cornea. So it seems that the tube has created some problems in the cornea. So this was 25 years ago, and that was the appearance, which is definitely cosmetically very unacceptable as well. And for that reason, I thought that the valves are behind a lot of complications that could happen in the future. And I was so much restricted in the use of the glaucoma drainage devices. And when I face a case of secondary glaucoma or a refractory case of glaucoma, I was so much inclined towards cycloablation that definitely pushed my abilities too much in the area of cycloablation. And I used to do a kind of comparison, which is a bit towards the cycloablation, like the cycloablation is more titratable, and then it's applied for our eyes, and then the corneal endothelium. We know that the valves could reduce the corneal endothelium, and then the subsequent procedures after the valves could be multiple, could be few after the cycloablation. And again, cost effectiveness, you can think that the valves are definitely more expensive. The cycloablative procedures are more repeatable. The technique is rapid, and it's an outpatient procedure, extraocular, few minutes. So again, I tried to put everything in favor of the cycloablation, as you can see, to be away from the valves as much as possible. I did stop practicing valves, but I know that I can have lots of complications following valves implantations. And also I published in the Egyptian Journal of Ophthalmology together with my colleague, Dr. Halal Hilali. At that time, that the complications of Ahmed valve, we applied the valves mainly on the pediatric age group and some others, and definitely we reported a lot of complications. So that's why I was away from the valves. So what happened recently? A few years ago, I started to feel a desperate need for the valves, as I'm facing kind of cases which need which are suitable for valve implantation. And also I have seen that, yes, cycloablative procedures are quite good, but you might need a lot of repeat, and then a lot of debates in case you have an eye with very good visual acuity. So I felt a need for improving my abilities in the valve procedure. Besides that, in the era of COVID, we had the opportunity to communicate and to meet lots of my friends virtually, and some of those were really giants in the field of valve surgery. They motivated me more and more to resume this part of my career. So I started to go extensively into the area of the valves once more, like a few years ago, and now gaining more experience and harvesting better outcomes, as I'll mention later. The general principle of a valve, that the valves are generally developed for the treatment of the complex cases of glaucomas. Any valve, there is a plate and a tube. The tube is inserted inside the eye, and it will take the aqueous from the anterior chamber to the surface of the plate that is secure to the sclera. Now, around the plate, there is initially a bleb, and this bleb will have a fibrovascular coat, so it will form a capsule, a fibrovascular capsule. Now, the wall of this capsule will control to a great extent the flow of the aqueous from the capsule to the surrounding space, so that again, this periplate fibrous capsule will play a role in the control of the intraocular pressure. So if there is a good flow or communication between this bleb or this capsule and the surrounding space, now the pressure will be fine. If this capsule is applying too much pressure and doesn't allow the aqueous to go outside of it, now the pressure will go up. We will face troubles. So a lot of work nowadays and years ago, how to control the permeability of this periplate fibrous capsule. This periplate fibrous capsule is formed around 4 to 6 weeks, and that's why this area, this period of the management is very important, because something is happening around the plate. The available implants nowadays in the market worldwide, we have the valved implants, and they have a kind of valve, two membranes. They apply a kind of resistance to the flow of the aqueous, so that once you put the tube inside the eye, the aqueous will go out. But if the pressure goes down below 10 or 8, those membranes will collapse, so that no more aqueous will go out. So it looks like an advantage in the valve implants. And on top comes the Ahmed glaucoma valve. And the Ahmed glaucoma valve, the common one we are using, the flexible plate 7. I think my colleagues are using this one with the surface area of 184 square millimeter, and it's formed of silicone, so it is soft. The implantation and manipulation of this is relatively soft. There are different types, but this one is in common use. Now, when it comes to the non-valved implants, and why do we have non-valved implants? Because non-valved implants, now the aqueous will go outside the eye through the tube. If you do not apply any kind of restriction to the flow, the pressure will go down and you will get into hypotony. That's why those types of implants, you need to do something to prevent the flow or to decrease it, like to ligate the tube, like to put a suture inside the tube. You don't want to pass into hypotony. And the idea of that, it is just you will go a period where the periplate fibrous capsule will form, and then the aqueous will go easily through the tube. So you ligate the tube with some absorbable sutures. On top of the non-valved implants comes the Barvelt, and we have the Barvelt two sizes, the small one 250 and 350 millimeter square, which is more commonly used, the 350 square millimeter. And then the company of Ahmed Valve, they have produced the Clear Path, which is a product, or it's an Ahmed valve, but without a valve. So it's a valveless, like a valveless Ahmed valve, and it's now getting into the market, Clear Path, and a lot of surgeons are using it. And it comes in two sizes, 250 and 350. And then also Molteno nowadays is trying to come back. Molteno was the initial good implant, but that was in 1986. And then Molteno is coming back with the Molteno 3 design. which is again one of the mostly non-valved implants, and it's available now in the market. And this is the clear path, which is the product of the New World Medical. And these are the two sizes, and it comes actually with the suture, with the 4O Prolene suture that occludes the tube temporarily. And then this is the Molteno tube. Again, it's trying to come back to the market. Now to the left here is the Barveld implant, or there is an Indian version, which is the Orolap, which is like the Barveld implant. It's a large implant which has to go underneath the muscles, so that it's a bit more difficult for its insertion. And to the right side, we'll see the Ahmed glaucoma valve that we will see later. Now to the left, it's my pleasure to have this photo with Dr. Molteno. Dr. Molteno passed away, but this picture, I had the pleasure to have this pic during one of the meetings. And Dr. Ahmed Mateen, the inventor of the Ahmed glaucoma valve. Then the question is when to implant. Implants are basically introduced as a second procedure. It means that you have performed your initial surgery, like trabeculectomy, and then the trabeculectomy have failed, and then you can see a lot of scarring. You will move to another step, and then you will go for a valve. So it's usually a second procedure, and it was introduced basically as a second procedure. But nowadays, there is a growing interest in being a primary procedure in cases where the trabeculectomy is expected to have a low success rate, like when you deal with neovascular glaucoma, uveitic glaucoma, and some cases of developmental and juvenile glaucomas. And nowadays, there is a growing interest to consider it a primary procedure for uncontrolled primary open-angle glaucoma. And when it comes to the States, quite interesting, there is a decline in the performance of trap, and there is increase in the performance of valves. So there is a generalized interest in the use of valves with growing experience in this area and the management of the complications and better outcomes. Other indications, traumatic affected pseudophakic glaucomas, post-keratoplasty, so that again, most of the difficult cases of glaucomas could be managed with the valves. So that was like the management options for primary open-angle glaucoma, and you can see the valves come at the end of the list when everything is done. But nowadays there is a trial of push to get it more, and with increasing in the experience of the surgeons, they are using it as a primary procedure in patients with advanced primary open-angle glaucoma. When I plan my patient for a valve, usually I put my patient on the slit lamp and I have a look on the superior conjunctiva. This is very, very important because some patients under the influence of the anti-glaucoma medications and senility, they get the conjunctiva very atrophic. They get the conjunctiva very adherent to the episclera. Now in those patients, it doesn't seem logical that I'll go for implantation of the valve. There is no room for the valve, so that I do that intentionally. I test the mobility of the conjunctiva so that I know in advance I don't want to go to the OR and then I find the conjunctiva plastered on the sclera and then I have to change my procedure. So again, I test the conjunctiva. Then I have a look on the iris, because patients with the secondary glaucomas like the neovascular glaucomas, sometimes we do inject with the procedure of the valve. We apply the valve and we inject anti-VEGFs. So if we have NDIs, we inject at the same time. We look at the anterior chamber depth. If the AC is shallow, we do not put a tube unless you do cataract surgery at the same time, because you cannot leave the tube very near to the cornea, otherwise the cornea will suffer. Gonioscopy is an integral part of all glaucoma examination procedures. You can find, if you plan to put the tube up and temporal, then you need to check there no peripheral anticyanic, something here that the tube will face in front at the time of introduction. The state of the lens is very important. If the patient is having cataract, then you are planning for a combined phaco and cataract, and then a patient, pseudophakic patient, and those patients are so many, and then those patients, you can place the tube in the sulcus, you know that. You can place the tube in the sulcus, And in patients after vitrectomy or affected patients, still there is a place for Parzaplana implantation. Now in the OR, when you see the patient with this picture, so much adherent conjunctiva, there is no way to go for a valve, whatever dissection you will do, so that I just make it a shortcut and I go for diode. Again, here, there is no conjunctiva. The conjunctiva, this is so obvious, but some patients, you will discover this on the operating table. So it's better to know in advance. If the conjunctiva is very adherent, I'll go to my beloved cycloablative procedures. There is no way to dissect a conjunctiva that's very adherent to the sclera. Regarding the anesthesia, definitely the surgeon has to be comfortable. This is very important. And also the patients who are very young, definitely general anesthesia might be good for them. But adult patients, still the peribulbar and retrobulbar block are very good for those patients. At the time of the surgery, these are some surgical tips. I need to open the conjunctiva. I open a large incision of the conjunctiva extending from the superior rectus to the lateral rectus if I'm going to operate on the upper temporal quadrant in the majority of the situations. And I usually adjust my microscope so that I'm facing this quadrant so that this will make the work easier for me. Sometimes when the orbit is tight and the exposure is difficult, you can use a superior rectus traction suture. This will facilitate the exposure. So the most important item while putting an implant, you need a good exposure. You cannot place the implant in an area where there's a lot of fibrous tissue or the implant is not resting easily. You cannot do that. The implant will migrate anteriorly. And alternatively, we can place a corneal traction suture, which I think most of my colleagues and myself are doing this nowadays. Corneal traction suture applied to the superior cornea, sometimes to the inferior cornea. But anyway, I think this is the one used nowadays, 7/0 Vicryl on a spatulated needle. And you can see the marks because before the operation, I do the marks. And why do I do that? Because sometimes the eye rotates and then you are confused. Where is the lateral rectus from the inferior rectus? And believe me, that could happen. So that I make it easier for me that while I'm at the 12 o'clock position, I do markings of the lateral rectus and the superior rectus. And then I put like the place of the tube, which is supposed to be here. This is not definite, but again, it is just expectation. And then I do measurements. I like to have the whole area clear like that. And it is centered between the lateral rectus and superior rectus here, and then this distance I go for 12 millimeter. What's written in the books and what I used to do is to put the implant an 8 to 10 millimeter so that the implant is usually visible. Nowadays I switched my technique to move the implant posterior, and I'm so happy with that step. Though it is technically difficult, but I think the benefit of this procedure is quite good, and it has been internationally accepted step. So that I do initial measurement like 12 millimeter, and then I divide this 12 millimeter into 3 millimeter parts. So 3 millimeter, 3 millimeter, 3 millimeter, and 3 millimeter, 4 parts of 3 millimeters. And then I create scleral incisions using the crescent. The crescent is a very helpful dissector for the sclera, but just beware if the crescent is very sharp, because it can cut through the sclera, and as I'll show you next week, inshallah. And then I divide this area again into 3 millimeter areas, and then I start dissecting tunnels. When I dissect the tunnel, I use the crescent blade and I make it on the surface of the sclera. I don't use it like perpendicular. It is just, the foot is resting on the sclera. So I'm applying pressure on the sclera while dissecting the implant. And I need a second instrument as a counter pressure, so that it's a bimanual technique, because if you dissect with the tunnel with the crescent, sometimes it keeps dissecting and it doesn't come out. You want to make the tunnel 3 millimeter as I'm planning, so that I use the second instrument to depress the sclera. While depressing the sclera, this will help the crescent to come out. And again, now the crescent has come. And then I dissected the rest of the tunnels. And then the third part is a flap. I dissect a flap like that after trabeculectomy. And definitely I'm just presenting what I'm doing. And I know there are hundreds of modifications, and definitely I'm having experts with me, Dr. Ali, Dr. Hassan, Dr. Mazen, and lots of glaucoma surgeons. They are having their own tricks, but I'm just showing what I'm doing in reality. And then the scleral flap, it's better to be a thick flap. It's different from the deep sclerectomy, which is a thin flap. I like to go for a thick scleral flap. So now before I proceed forward, then I put the sutures of the implant. So it's like pre-placed sutures. So that sometimes we put the implant and then we go for the scleral sutures of the implant. But I'm working posterior, like 12 millimeter, which is not easy. It needs a bit of training for me and for the assisting nurse as well, for the scrub nurse. So I use nowadays to place the sutures before I proceed, and then I put it the other suture, and then there is a loop which I cut, and then we have two sutures. So I do that before putting the implant. This facilitated things for me. Then I do priming, as you know, by injection through the valve. We do not inject vigorously. You can damage the membranes. Gently, once you see the fluid coming, that's enough. And then the implant should go smoothly. And one of the tips here that I use the artery forceps to separate the tenons layer, so that I don't use scissors, because scissors sometimes they can damage the tissues. The artery, especially the artery which is curved, so that it has a curve on the sclera, and then I open, and then it will help the separation of the tenons effectively. And the good point is that the implant will go smoothly. And then this is here the pre-placed sutures I place, so that I put the sutures on the implant while I see everything. Before I'm working posterior, definitely that was not my technique earlier. I used to put the implant and suture. And then after I fix the implant posteriorly, I hold the tube, and then I go through the tunnel. So from one tunnel to the second to the third tunnel. So we have 3 tunnels. So it looks like a long tunnel, but I cannot dissect a tunnel that is 9 millimeter with the crescent. That's very dangerous. So that I'm just dividing, and those spaces sometimes disappear completely. So it seems like one tunnel, like here, so that it looks like a tunnel. Now, while doing that, the remaining part of the tube is short, because in the old days, when I put the implant like 8 millimeter, the tube is around 20 millimeters. So I find a long part of the tube to cut. But once I place the implant, the plate now posterior, the remaining part of the tube is usually not too long. I make it beveled, and then we pierce the limbus using the 23 gauge needle. We can have this needle connected to helon, so that once you inject helon, that helon will fill the anterior chamber and will lubricate the entry side. Alternatively, you can make a paracentesis and I inject helon. So at the time of the implantation, I don't want to lose the anterior chamber. Either I inject helon in this area in particular to make it deep at the time of insertion of the tube, or I just take the needle on a helon. And that could be enough length. It is 2.5 to 3 millimeter. And I used like to measure the distance as half the distance from the limbus to the pupil. This one is a slightly longer, but I'll be satisfied when it is half the distance on the surface of the iris. So again, this is the video. So the dissecting the conjunctiva, it was a recurrent pediatric glaucoma or juvenile glaucoma. So you can see a lot of tenons. And then again, the artery forceps will help the separation. And in this case, I just wanted to have good exposure by hooking the muscle, but I do this very, very infrequently. I use the corneal traction suture. Now I like to see the sclera, and then I do diathermy as needed. And I retract the tissues, and then I measure 12 millimeters. Now, once the exposure is like that, I really feel happy. And I feel that I'm comfortable with the tunnels and the suturing. Then I'm dividing into 3 millimeter tunnels, as all of you see, just a landmark. And then I'm going to use the crescent. And again, I try to use the crescent gently, because if the crescent is very sharp, it can go inside the eye. So I dissect the those incisions. And then sometimes we can find remnants of episcleral tissues. You can take those away with the knife. And then after I did my incisions, again, dissecting the posterior tunnel, I found it easier to have the direction of the crescent from proximal to distal, so that from the cornea backwards. This is a much more convenient. Yes, you can do from backward forwards, but again, I found this one is convenient for me. And I'm sitting again in the upper temporal quadrant, and then going to the last part, it is a flap or a trapdoor. I know that some of the surgeons are just piercing the limbus and putting graft on this. Again, hundreds of techniques are available, but I dissect the flap, and then every now and then I make the field dry, and then I'm putting the non-absorbable sutures. Yes, I see that. I know, again, there are some schools which are using absorbable sutures, and there are some schools which are not using sutures at all. But again, I'm using non-absorbable sutures because the implant can migrate. And then passing this is non-absorbable Ethibond 5.0. You can use nylon 8.0 or 9.0 as well. And then holding the tube, it's very important. If the tube is long, you will not be able to hold it. So take a short part of the tube and make it very beveled. And then you can move it through the tunnel. And then once you get it, you will push it into the second tunnel. So it's again, just connected. They are all connected together. And then once you have this appearance, then you will cut the extra length of the tube. Again, the remaining part of the tube is relatively small. You make it beveled, and beveling is towards the cornea. If it is toward the iris can occlude it. Again, this is the moment of the piercing the anterior chamber. The needle will go parallel to the iris or even slightly towards the iris, but not towards the cornea. And it is the direction of the needle that will control the orientation of the tube inside the anterior chamber. You don't want it to be directed towards the cornea. So again, the eye is filled with helium at that time. I don't want to lose the anterior chamber, and I'm satisfied with this length. It's congenital glaucoma, you see recurrent, and I apply 2 sutures. Now, if the tissues are very thin here, I'll put scleral patch graft. If the tissues are good, so that now I'm satisfied and I will not do anything. And sometimes it is even the implant is greater than 12 millimeter. Now, again, it is just a revision of the technique, again, that is starting with the posterior incision, posterior tunnel, and then moving to the middle tunnel. Again, that everything is connected. And with time, I found this, it is reproducible, so that it is not difficult to reproduce once you train. And I trained myself on that. And as you see, this technique awarded the 2nd place from the American Academy of Ophthalmology in the global video contest this year. So again, this is the last part. Again, it's a flap. I know that you can do a tunnel, but with tunnel in my hands, it was not easy to implant the tube through the tunnel, so that I decided to make it like even a trap door, so that you can cut one edge, or you can make it like flap. So again, you can just gently push the tube. It will come because the tube is beveled, and then you will immediately move it. And sometimes you can take it without getting it out of the every tunnel, a single pass that everything will, you will a single pass, okay. And then putting the non-absorbable suture for the plate, which again, I'm insisting on the non-absorbable suture. I feel so much secure. And in this case, it was pseudophakic, so the tube was in the sulcus. As you see, you can put it behind the iris if you insert the tube 2 millimeters. And then with this technique, when you move posterior, you can see a huge bleb in the upper temporal quadrant. And this is usually linked to a very good control of the intraocular pressure. This is the appearance of the tube like 1 year after the operation, so that the tube is not very well seen. But sometimes a shadow of the tube is seen. And this operation like 1.5 years ago, I really don't know, but this could be further improved if you dissect the sclera deeper, so that with experience you can handle the sclera to have the tunnels deep and you have the flap deep as well. In the old days, I used to push the valve and then put the scleral suture. Definitely, this is not easy. When you ask the scrub nurse all the time, push the valve posterior and then try to find the space for the suture. That's why the pre-placed sutures before putting the implant facilitated actually my life. Sometimes I close the tenons separately. When I have a thick tenon, I make use of it. I dissect it from the conjunctiva and I secure a separate layer of tenon on the valve. When the conjunctiva in the perilimbal area is scarred, and that could happen, well, after a failed surgery, and then because the valves are usually next to the failed operation, so that I know the posterior conjunctiva is good, but the anterior conjunctiva is not, so that I'm injecting BSS deep to the conjunctiva, trying to form space, and I know that I want to dissect. It looks like a line of scarring, so that I'm trying to push the subconjunctival fluid and subtenon's fluid mechanically to try to get more and to create more of the subconjunctival space. I'm using the hook as well to try to get more of the conjunctiva anterior, because I don't want to cut the conjunctiva so much away from the limbus. So again, I thought now I'm relatively in a better position. And then when I cut at that time, I make sure that I'm cutting towards the cornea. So again, to harvest as much as possible of the conjunctiva. The conjunctiva itself is not bad, but the perilimbal conjunctiva is so much scarred. So again, I'm making use of this pushing effect to have more space. And at the conclusion of the surgery, it was easy to get these conjunctiva towards the limbus. So again, conjunctival hydrodissection, sometimes I do it. When I'm not so much comfortable with the scleral flap, I put a scleral patch graft and I cover this area. Now the patient is having cataract as well. And then again, after placing the valve as usual, and then this is the tip here, that I'm going to take this tube and place it inside the tunnel. You know that you cannot operate cataract while the tube is in the view. It will disturb you, and just take it back and just put it inside the second tunnel like that. And then I rotate the eye to do a cataract surgery without the tube obstructing my view. And now this is the conclusion of the cataract surgery with the lens implantation. And that was the site of previous scarring from the previous glaucoma surgery. Now the lens is placed in the bag. And afterwards, I'll move to insert the tube. So that when we have cataract, so simultaneous cataract and glaucoma surgery, you can implant the tube behind the iris. Make use of this 2 millimeter behind the limbus. You go parallel to the iris, and then you move, and you will have the needle coming between the iris and the capsule. So, and I inject heron in this area just to inflate this space and push the iris anterior to create a space for the tube to move, because sometimes the needle will pass in front of the IOL, but when you put the tube, it can move behind the IOL. Again, the tube is coming in the area where I love to see, and we need to see the tip of the tube. I don't leave the tube behind the iris and it's not seen, so that it could be occluded by the iris. So again, I touch it with the Senski. Why? Because sometimes you are confused whether the tube is in front of the IOL or behind the IOL. Just I want to make sure by touching this, and then I remove the viscoelastic. So this is my technique. Definitely, when the AC is deep after the cataract surgery, you still can put the tube on the iris, but you have the advantage here of placing the tube behind the iris, but make sure that you see the tube all the time. So this is again 2 millimeter behind the limbus, and you go parallel. So again, when you insert the first tube, you go parallel to the iris and sometimes towards the iris. When you insert behind the iris, you go parallel, but 2 millimeter behind the limbus, and then you will get into this space. Inject a lot of viscoelastic to facilitate the implantation, and then make sure that the tube is in front of the IOL and not behind. And this is the tube seen post-operatively. Uveitic glaucoma is one of the indications, for surgery, and you can see the atrophic iris from the attack of uveitis. Again, there is a growing interest in managing uncontrolled uveitic glaucoma with implants, because they think the implants are much more tolerant to the attacks of uveitis if it happens in the future, so that it comes. Yes, there are some other techniques. There is an angle surgery, there is trap, but valves, they come on the top of the list. So dissecting as usual, and this is the episclera here. It has its characteristic appearance, so that I dissect, then I go with my artery, my curved artery, and then I place it under the muscle just to create, to see this area, and sometimes I mark, because I know that my tube and my implant will be centered here, so that I divide everything as usual, 3 millimeters, so that it seems like a routine procedure. But with uveitic glaucoma, the most important is the integration with the rheumatologist and with my colleagues, because they give me some advice regarding the perioperative preparation. Usually we give steroids, systemic steroids, and we give short-acting steroids, and we inject kinocort at the conclusion of research. So again, dissecting the tunnels as usual. The technique is not different from one eye to the other, usually the same. And again, dissecting the third flap. It's a flap, but I will not. I'll do it like either a trapdoor or a flap. And here is again, look, I'm putting the suture in the implant before I place it. This will facilitate everything, especially if it is pre-placed. And then it is a routine surgery. Again, the most important with the uveitic glaucoma is not the technique, but it is rather the medical management and intraoperative and postoperative. This is one issue. And also, if the patient is going to undergo simultaneous cataract surgery, there is a general recommendation that the tube is in front of the iris, not behind the iris, because it can induce some friction with the back of the iris and activate uveitis. Again, you push it. It's very important that the implant will slide smoothly. It shouldn't come. Once you push it back, it shouldn't jump all the time. Otherwise, there is a lot of resistance. Again, this is one of the surprises, because everything was normal. I just dissected the sclera, but I realized the sclera is not very good in the upper temporal area. Definitely just came across my mind, is that a choroidal melanoma? What is that? And then I decided to move to another quadrant, and then I thought, no, I'll back to the same place. The patient's fundus was normal. There was no evidence of anything, but I know that this area of the sclera is thinned out. It's showing the choroid, but the clinical examination did not show something that's serious. And then I decided to do like that. I put the implant slightly anterior, and I use the implant to support this area of the sclera. I thought, if this is a weak area, so why not to put the implant on this weak area, and it's okay. So that I manage that, and then definitely post-operative, I made sure that the patient doesn't have anything serious in the eye. Now, this is a more serious situation, a patient with anterior chamber lens, and everything is normal. And then the conjunctiva looks very redundant, good conjunctiva, but look, the sclera, you have surprise. So that, again, when you do the valves, you can have some surprises like that. The patient pre-operatively doesn't have any problem. There is no retinal detachment, there is no choroidal mass. But again, you can see something. This is a show of the ciliary body, that pigmentation in the episclera. But again, it is very frightening appearance to see that. And you need to think, I need to take time. That's why I wipe a lot, just thinking what to do in this situation. Definitely, you can move to the inferior quadrant, but I don't want to do that, because I can face the same situation. The patient we could have this picture after a buckle, for example, but the patient was not buckled. So I decided to make the pockets in front and behind this area, and then to make the tube just crossing in front of it. And I was satisfied with this management. But again, just prepare yourself that you can face something abnormal in the sclera, something abnormal in the muscles, as long as you will get into the valves. And here I thought of dissecting the tenons separately. It's a huge, beautiful tenon, so that I just sutured the tenon separately, and then I sutured the conjunctiva, and everything went fine actually. But again, that was a surprise, and I'm now, after facing these two situations, I think I'm better in dealing with those difficulties. Now, in the upper temporal quadrant, you can see there is a staphyloma. There is an actual staphyloma. This is a visible staphyloma. Now, with this staphyloma, definitely we can't manage to put a valve that was a recurrent ophthalmos, so that I decided now to go to the inferior quadrant, so that if we are using the upper temporal quadrant, the first priority, the next priority will be the lower nasal quadrant, will be the next priority for the implantation. The other quadrants are the least to go through. So again, the dissection of the inferior conjunctiva and the place for the valve is not difficult at all, and a good indication for the inferior placement patients with the silicone oil, because we know patients who are having eyes filled with silicone, sometimes they have silicone coming from the back of the eye and they float up, so they can occlude the tube. So that it's a policy to implant the valve inferiorly if you are going to do so. Again, the dissection, there was no problem and everything went fine. But again, I'm just showing you that we can face some difficulties that can compel us to change the area of implantation. So again, if I notice this, pre-operatively, it was not very obvious, by the way, but under anesthesia, I could see this clearly. I did not open the conjunctiva over it. I just dissected the inferior, and it is the same procedure applied for a superior placed one. Now, for the ophthalmic eye, you know that lots of tenons, so that expect a hill of work to separate the tenons, and you are confused between the tenons and the muscles. And anyway, you will take more than usual to clear the surface of the sclera, and you are left with remnants, because this is a recurrent again with high fibroblastic activity. I'm dissecting the sclera flap, and yes, you can expect that the sclera thinned out, and you might need a scleral patch graft. It's okay. You are prepared with everything in case you need it. But again, there was no big problem with the priming of the valve. We do not inject too much. But for the ophthalmic eyes, especially for the very young kids, usually we leave a long part of the tube. However, personally, I don't like to put an implant on the very young kids, like 1 or 2 years. I'm a bit cautious in this age group. And then this is barbell or orolab. I'm not using it actually because it's very bulky. It needs a lot of work, and the wings will go underneath the muscle. And this is one of the non-valvular implants. That means after you fix the plate, you need to ligate the tube. You need to ligate with absorbable sutures. I put 2 absorbable sutures until the periplate capsule is formed, and then it will spontaneously work. So that I'm closing the tube, and some surgeons are doing doing a kind of perforation of the anterior part of the tube, a kind of venting, so that not the tube, not to occlude everything, a kind of anterior venting of the equus. So the tube is occluded temporarily here, but I'm not using it. I'm not actually. It's so bulky, so that I feel in my hands that Ahmed valve is better. So that the surgical techniques, again, if I'm going to revise, yes, double-armed vicryl suture or spatulated needle to help the exposure, large conjunctival incision, be comfortable. Large conjunctival incision is very important. Good exposure of the sclera, take time for the exposure and removal of the episcleral tissue. Just make sure that all the way to the sclera is very clear. I'm using tunnels, the priming, the fixation with non-absorbable sutures. You can use 8 or 9 or nylon. I'm using Ethibond. And then restriction of the flow in non-valved implants is not common actually here in Egypt. Insertion of the tube, and then just coming to the points which I think they have shifted my career in this area. So that what are the secrets, which I think the secrets behind my great interest in the valves nowadays. That is, first of all, is the posterior placement of the plate. It is technically difficult, but I think it's very rewarding when the plate is very posterior because the tenons in the posterior part is very thin. I found this, the tenon is very thin, that could help the better pressure. So I think that's something good. Tunneling of the tube inside the sclera so that I don't see, nowadays, I don't see a scleral tube erosions or exposure. So that definitely, I don't know in the long term, like after 5 or 10 years, what will happen, but the tubes are really good inside the scleral tunnels, and the intraocular part of the tube is away from the cornea. So that I got some cases of cornea decompensation because the direction of the tube could be towards the cornea, but nowadays I make sure it's towards the iris, or at least parallel to the iris. So I think these are some of the critical points that dramatically improved my outcome in dealing with the valves. And they moved from the area of being like, I have a lot of questions around the valves to a procedure which I really love and I advise, especially when there is a good indication for the valve. Now, why do I believe that posterior fixation is good? Because I found this article, actually, I found this nowadays, why the results are better, why I found better IOP control in my hands, because more posterior tenons capsule, very interesting, thinner and more translucent. This could be part because we cannot open the orbital fat. Don't think that if the plate moved posterior, it will go into the orbital fat. No, this will be a complication. We don't want that. It is still underneath the tenons, and the tenons extends down to the optic nerve, so that it's still in this place. But the tenons here is thin, and the tenons is the source of the periplate fibrous capsule encapsulation. So that I think the tenons here is anatomically more, it's accepting more of the aqueous, and the capsule that will form is not very hazardous capsule. So that, and actually they found some smooth muscle fibers in the tenons layer anteriorly. They are not existing posterior. So I think there are some features in the posterior tenon that help better outcome. So that nowadays I hate those valves. So that when I just open the lid and I see the valve, I know this is the area where a lot of fibrous activity, a lot of scarring will happen around the implant. So look at this girl. She received a bilateral implant, so that you can see the right eye. The implant is very prominent. The left eye, there is nothing, but she received an implant for this. She's an only eyed patient. This eye is an absolute eye with the implant very anterior, you see. And this one, there is an implant which is very posterior. She has very, very advanced feed loss, and she's soiled. But again, when you see that the valve is placed very posterior, so cosmetically, even very, very acceptable to the patient. So that nowadays, I just tell them that the appearance usually is not very bad. Do we have to apply anti-metabolites? You know, with the glaucoma surgery like trap or deep sclerectomy, we put anti-metabolites. It's a part of the operation. But for the valves, lots of debates, but the conclusion nowadays, they are not very helpful for the glaucoma drainage devices, and a lot of research is going on, but there is no evidence-based for the use of any kind of anti-metabolites scientifically. Then the post-operative course is usually we use antibiotics and steroids for 4 to 6 weeks. That's the time of the control of the time of the periplate fibrous capsule is formed, and we are expecting here. For the valved implants, usually we stop. So like Ahmed valve, if the pressure is too low, we stop. But if the pressure is going slightly up, and I'll tell you just the policy of this right now. Anyway, for the non-valved implants, if you decide to put Montino or Barveld implants, just put the patient on all anti-glaucoma medications, because usually the valve doesn't work in the early post-op until the suture is removed or it dissolves around the tube. Just one more point on what's known as the hypertensive phase, because one of the side effects or one of the known complication of the valves is what's known as the hypertensive phase. We have to be aware of it and how to manage this hypertensive phase. Now, this hypertensive phase, why do we get hypertensive phase? Because of the periplate capsule that's forming, and at some moments, at some times, it doesn't allow the aqueous to go through, so that the pressure here is, we can get a kind of elevation of the pressure. By definition, a hypertensive phase, it's called any pressure above 21 millimeter mercury in the first 3 to 6 months. In some reports, 3 months or 6 months. In this period, if the pressure is above 21, which is the upper acceptable limit, we call this as a hypertensive phase. And it develops in a lot of patients, look up to 82% of patients. And sometimes it is persistent and the pressure will keep elevated, and then we will get early failure of the implant, so that we need to be aware of that. The hypertensive phase is more common with the Ahmed valve because Ahmed valve is working from the first moment, and then the aqueous is playing a role in this hypertensive phase. But again, it could develop with all implants, with the Barveld, with Montino, everything. And why does it happen? Why the pressure goes up? Again, a lot of the inflammatory cytokines are present in the glaucomatous aqueous, because the aqueous of the eye, where the pressure is not controlled, is different from the aqueous of the normal eye. A lot of inflammatory cytokines, interleukin, and a lot of inflammatory mediators, which were inducing a lot of inflammation around the plate. And then higher preoperative IOP and high myopia have been demonstrated in regression analysis as a factor for the hypertensive phase. And the valved implants show greater hypertensive phase. Why? Because the valved implants, from the first day they work, they allow the pressure, the aqueous to go. So the pressure will go down. This is an advantage. But at the same time, that glaucomatous aqueous will help the initiation of the periplate capsule, because it has a lot of inflammatory cytokines. So eventually the pressure will go up. Once this capsule is becoming mature, the pressure can go up. And the capsule initially is thick, and then it becomes thin. As the capsule becomes thin, we can expect the pressure to go down, or the pressure will go up because of cross-linking that happens in the wall of this fibrous capsule. Anyway, the valved implants have greater tendency to have the hypertensive phase, but at the end of the day, there is no big difference between the valved and non-valved implants in the pressure control, but there might be some greater pressure reduction with the non-valved implants on the long term. But again, the difference is statistically significant or not. A lot of debates in this area as well. How to manage the hypertensive phase? Now you have put an implant and the patient comes after 2 months with pressure elevation. And then definitely you can feel a bit frustrated because it's a big surgery, and sometimes it's a costly surgery as well. So how to manage this? A lot of debates around the role of the anti-metabolites. We know they don't have to do anything with the valve. Again, some studies suggested it might have to do something with this hypertensive phase. If you encounter a lot of tenon, the tenon is the source of this capsule. So some suggested resection of the tenon, intraoperative triamcinolone subtenon, supratenon capsule implantation. Some reports that to place the implant on the top of the tenon. This is technically very difficult, but also can lead to erosion of the conjunctiva. But again, thinking of this. But what's really common in practice is to use aqueous suppressant, so that if the pressure is greater than 10, so the pressure is low, we prescribe the patients a combination of beta blocker and topical carbonic anhydrase inhibitors. And this is expected to reduce the amount of the aqueous going through the implant with its inflammatory cytokines, so that, and the periplate capsule is expected not to have a lot of scarring around it, so that it reduced this hypertensive phase to 23% versus 66% in those who are not using the medication. So that as a routine, I prescribe the patient everything, and then I put the patient on a combination of beta blocker and carbonic anhydrase inhibitor for 3 months. The only indication that I do not go through this regimen if the pressure is very low. The pressure is 7 or 8, so that I don't. But if usually I put it as a routine. The other good point is the ocular massage. We found that when you do an ocular massage, you can push the aqueous, and that aqueous could have some mechanical effect on this periplate fibrosis. Do we have to do needling? Very rarely. Very rarely to manipulate the valve post-operative. But again, if you have seen tenon cyst, you still can needle this cyst. You can inject some anti-metabolites at the border. There is a chance for that, but again, this is not common in my practice. What I do post-operative is just medical management of the pressure post-operative without doing too much interventions. And if the pressure eventually fails, look, this patient received 2 implants, and then the pressure is eventually very high. What I'm going to do, I'm going to go for a cycloablative. My beloved cycloablative procedure can go for continuous wave or micropulse. So we have something to do. By the way, some patients believe that if you are going to do valve, this is the end of the road. You have nothing else to do. I used to tell the patient, we always have something to do. Always have something to do, so that now we can move to the cycloablative procedure with a continuous wave, with a micropulse, with an endoscopic cyclophotocoagulation, whatever, but we still have something good to do to my patient. Now, in conclusion, the valves are generally, there is a growing interest for the valves nowadays. What we really have is the Ahmed glaucoma valve, and I like very much the changes that I have introduced to this area of moving the plate posterior and then doing complete tunneling of the tube and having the tube away from the cornea and have it enough length inside the eye. I do expect the pressure post-operative to have a kind of fluctuation to go through the hypertensive phase, but I know how to manage. And at the end of the road, which is really very, very uncommon, if the valve fails, you can go for another valve, but you can go for cycloablative procedures with its advantages of repeatability and availability of different techniques. And with that, I thank you very, very much.
Thank you, Dr. Ahmed. Thank you for this nice presentation.
Allah yakhallik, Ali. How are you, Ali? I'm happy that you are here.
Alhamdulillah, yeah.
And Hassan, I'm happy that Hassan is here too.
But why push Dr. Mazen away from glaucoma? He's still some hairs on the head. Let him go to the glaucoma also.
I didn't, you know that I love him to the extent that I don't want to involve him so much in the glaucoma, so that keep him with the smiling, refractive people. He's too young for that. Yeah. Dr. Hassan, assalamu alaikum. How are you?
عليكم السلام دكتور أحمد الله يعطيك العافية. ما شاء الله ما شاء الله دكتور أحمد, you kill the monster. ما شاء الله تبارك الله. ما شاء الله. يعني actually you covered the topic from A to Z. ما شاء الله ما شاء الله.
Thank you so much. It is just my I know that it's quite easy to mention what's written in the books, but I just want to transfer what I'm really doing in practice, which could be quite different. But at the end of the day, everyone is so much comfortable by what he is doing, and we are all ready to improve, by the way, so that I know you and Ali and others are having different opinions and different schools. That's why I'm happy that you are here.
Yeah, also we are happy only to learn from you, Dr. Ahmed, mashallah. Dr. Ubaida and Dr. Basil also joined. Dr. Ahmed, if I have many questions, always this have a problem. Said about the encapsulated. Are you try for the needling? I think is 100% will not work anything. If work for 1 week, 2 weeks after that failed. For that, I now when have very dense encapsulation, I didn't decide to make any needling for any AGV. What's your opinion about that? Are you still try to do that or not?
Look, Dr. Ali, for my valves, I don't see my plates anymore. The first and last time I see my plates on the operating table, because afterwards they are placed so posterior, I cannot needle them. There is no way of needling them. But this patient, which I have shown, is not mine. I just came with a periplate tenon cyst, so that I thought I could help him with something. But in my practice, I don't even advise cutting the fibrous capsule, because there are some reports on opening the conjunctiva, creating a hole in the periplate, and then suturing the conjunctiva. What will happen? That fibrosis will come back. So that actually, Dr. Ali, I don't, for myself, again, if we are just transferring kind of knowledge and experience, I don't do any interventions in the post-operative unless there is something which needs management, like tube occluded by the iris, occluded by the vitreous, as we will see next week. But as in a straightforward case, I don't do anything. I totally agree with you. I totally agree.
Yeah, for that, there's many doctors saying this is for blade needling as for trabeculectomy needling. Trabeculectomy needling 100% is working very well, but yes, with AGV is 100% will not working, because I tried many times for many years on 100% failed later. For that now, if I decided to go to another CBC, another AGV and another blade place, but 100% I will not go to needling. Another question about the tunnel. 100% covering the tube under the sclera is more cosmetic and so much more beautiful after the surgery. Only one point, when you find the stiffness for the tube, the direction, always this is control the sclera, control your direction inside the eye, because you go through a thinner sclera when you go inside the eye. For that, I compare many of my patients. This is under the sclera on the patient cover, the tube covered with sclera or totoblast. I found this is the tube is the direction is more away from the cornea and can control the tube direction more than under the sclera. This is my opinion, my experience. What are your opinion about that?
Well, Dr. Ali, just believe me that sometimes some of my patients having iris stuck into the tube. So that again, when you insert, you know that the point of entry into the eye is not a point, it's a tunnel. So that when I go underneath a scleral flap, and then when it comes to the limbus, and then on the posterior boundary of the limbus, you penetrate. This is not a point. You will go through a tissue, and that tissue will control the direction of the tube. So that for me, it is very uncommon to have a tube that's going towards the cornea. On the contrary, that sometimes I find my tubes moving towards the iris, and I adjust them slightly anterior. So that the advice here is that you just go parallel. You just make the eye, you know, that you adjust the position of the cornea, and then you go parallel to the eyes. I really don't know whether to have it under a sclera flap or just on the sclera will make a difference. I really don't know. I didn't compare that, but in my hands, I don't have a tube that's moving towards the cornea.
Yeah, I have one comment, Dr. Ali. Assalamu alaikum. How are you doing? Yeah, I have one point here. It's very important. It's very important tip here while entering the anterior chamber to go slightly towards the iris. Once you go slightly towards the iris, the tube when inserted the tube, it will be parallel with the iris. So very important tip while you are entering the antechamber.
Yeah, because
don't go directly in the midway of the antechamber, and don't go with the parallel plane of the iris. When you go just slightly to enter the antechamber towards the iris, without damaging the iris, when you insert the tube, it will go slightly up by the scleral flap or by the scleral tunnel.
Yeah,
yes.
You have right.
The most important, you need to make just the tube beveled, because if you are, near to that kind of close, so that it's beveled. And also you need to, in my hands, I need to inflate this area with heron at the time of insertion. I don't want to insert a tube in an anterior chamber that's shallow. I will not be able to judge the direction of the tube. I would love to have it implanted inside the heron. Ali, please. Alaikum assalam, Dr. Basil.
Dr. Basil.
Assalamu alaikum. Dr. Ahmed, thank you very much for this informative lecture and presentation. We learned a lot from you as always. I will agree with you about the anterior flap. It is helpful indeed. And my old practice in Ahmed valve implantation to create a scleral flap exactly as in traps, and to insert the tube in the anterior chamber, then to put a scleral graft patch 3 millimeters away from the limbus to prevent any delay for the cornea in future. And recently, I learned from you how to create these 3 or 4 flaps and to put or to insert the tube totally, yes, inside these tunnels. For the direction of the tube inside the anterior chamber, what I'm doing usually, I'm taking a flap half thickness of the cornea, of the sclera. I'm talking about the anterior flap. And when I'm inserting or creating a tunnel with a 27 gauge needle or 26 gauge needle, I'm not going directly to the anterior chamber. I take it a little bit to the right or a little bit to the left. That will give me longer path inside the tissue. This will give me more control to the direction of the tube inside the anterior chamber. I think this point will help us to overcome the misdirection of the tube forward the cornea by making the insertion of the needle during creating the tunnel a little bit tilted to the right or a little bit tilted to the left. This will give us extra tissue to keep the tube in direction away from the cornea.
You mean oblique entrance into the antechamber.
Exactly.
You know, Dr. Basil, sometimes you have patients with insufficient iris tissue, and you need to have the tube resting on the iris. And then you are obliged to move the tube in an oblique direction to have the tube on the iris. Thank you very much for this. Thank you very much, Dr. Basil. Yes, thank you.
I think also the scleral thickness, the scleral flap thickness is very important in, and when you have a very good thick scleral flap, when you have a thick scleral flap is better in adjusting the direction of the tube than you have a thin scleral flap.
Yes, I totally agree with you. This is different from a deep sclerectomy. Because of the deep sclerectomy, I opt for a thin flap, but the mindset that while doing the valve, I go for a thick flap, unless there are some obstacle like the sclera is thinned, or we will see, I think, next week a lot of horrible cases that allow us to go out of the menu and then to think.
And also, Dr. Ahmed mentioned for all, but I think we didn't still have any experience with bowel glaucoma implant, PGA. Yes. Are you try that or still? Because
no.
if it will work, it will be very, very good, because the tube is almost half of the Ahmed glaucoma and Bervelt, and will be very good to be more away from the iris and from the cornea. I hope that.
Yeah, definitely. But you know that Ahmed and Bervelt will not give enough room for it to spread. They will invent more advantages.
Dr. Ahmed and my colleagues, if you can accept my notice about the recent iWatch drainage system. Indeed, the tube or the puzzle of the watch is rigid. It's not as in Ahmed valve or in Pervelt. So it's you will not be worry about the direction of the tube in this case, because it's rigid indeed, and it will be parallel to the iris.
Interesting. That's an interesting. We don't have it actually in Egypt yet, so that there is no experience. Now, do you think the glaucoma implants are for general ophthalmologists or for glaucoma specialists?
I can even not for general specialists or for general ophthalmologists.
Yeah, please.
Yeah. Actually, I always I'm very strict about subspecialty. I always say that it is not only the technique, the surgery. If it is only the technique or the surgery, some technicians are better than many surgeons in doing surgeries. But the issue is how to follow up the patient and how to manage a complication. It is very similar to refractive surgery. It is not that like I put my foot on the pedal and push it, and then the laser machine will do the job. It is how to study the patient, how to put the indication, how to avoid complication, how to manage complication if they occur. I think saying that valves or MIGs or microsurgery is underestimating the such procedures. They give an impression that they are very easy and anyone can do it. While I think the more microsurgery, the more delicate, and the more it needs experience, especially how to manage if something went wrong. So I usually refer the cases of such. I treat medically for glaucoma to some extent. Then when I feel that it is the time for intervention, I refer the patient to glaucoma specialist. So this is my opinion. Yes, yes. And I'm always like this. I don't allow any general ophthalmologist to say something else.
And I actually asked this specifically for you because you are the only one who is not a glaucoma specialist. So that I asked this question just to allow you to contribute. So definitely we totally agree.
Dr. Ahmed, after this experience, sometimes you open the eye, especially for young patient, and you cannot decide the result. Yeah, the young patient, myopic patient on congenital glaucoma. You open the eye and you feel yourself that you open for operation for the first time. You didn't know where is the sclerospore, where is the ciliary body, and you see this is as disoriented in this operation. This is the problem with the glaucoma. This is sometimes you feel this is your experience stopped on this patient on not working. For that is different from even for refractive surgery. Dr. Mazin, mashallah, we did a very big amount of refractive surgery with him on Syria. But even this with the refractive surgery, you learn how you make the surgery. The machine help you. But after that, you have good experience. Unfortunately, any glaucoma, even with this experience, sometimes you find yourself is no any experience in some cases.
You know a big difference between the glaucoma specialist and other specialties, that you are having a kind of long-term relation with your patient. I don't know that this is so much existing with refractive surgery, because with refractive surgery, you tell the patient, if you have any problem, just come back but you don't have to follow for anything. But for glaucoma, you're having a kind of relations, and then you appreciate the value of this relation with time. And some patients are so much linked to the life by this relation. And then they are having like one eye and advanced damage, whatever the age is. And they just want to know that they are fine. No one else can convey this message that you are fine unless a glaucoma specialist, because if you are an other specialty, I think you cannot say that from the bottom of your heart that you are doing fine. So that I think that the glaucoma specialists, they do something else, which is a kind of deep relation with the patients, which is really very helpful it's very helpful for the glaucoma specialist as well, but it's of great advantage for the patient.
For that, Dr. Ahmed,
sorry for interruption. I heard that from Professor Tariq Sha'rawi, that glaucoma specialist marries his patients.
No, this is what I want, Dr. Mazen. That's our teacher, Dr. Joseph Fatouh. No, this is Dr. Mazen and all Dr. Hassan, Dr. Basel. This our teacher in Syria said this is a glaucoma patient is a partner in your clinic. That is better to choose your partner.
Dr. Ahmed, yes. I have one point about the non-absorbable suture and fixating the plate with non-absorbable suture. Actually, I use absorbable suture, Vicryl, 7O Vicryl, in all of my cases. But now more than 12 years, I'm working with Ahmed valve, but I don't have any migration. I think here, the first point is about the encapsulation around the plate, the fibrous capsule around. I think it is responsible about preventing the migration of the plate anteriorly or posteriorly when you have a good fibrous capsule formation. And you know that the Vicryl suture take about 4 to 6 weeks to absorb, and it's the same time for encapsulation around the plate. This is what I'm use in my practice.
I know you are doing that, and it should be perfect at that. I know there are different schools, but the recommendation, I think, is to use non-absorbable sutures, because I have seen eyes where the valve is posterior, but on moving the eye, the tube moves inside the eye. So that the presence of the periplate fibrosis does not prevent the movement of the tube inside the eye, and may have the opportunity to present this next week. So the tube can touch the cornea, can be all the time moving inside the eye. So that the recommendation is to go for a non-absorbable. You definitely have a good experience that you need to publish on that. And I have seen some colleagues are putting the clear path even without sutures. But you know that I have seen patients who come with valves that's just coming onto the cornea when I explored no sutures. So that I know that also, they could be successful. Yeah, in some cases, but complications could happen.
And also one point is one important point in while you are using the tunnel technique, 3 tunnels technique. I think also, this is tunnels will prevent migration as you make 12 millimeter away from the limbus, and you create 3 tunnels, and the posterior tunnel will prevent migration anteriorly, as the plate will be secured by the scleral tunnel.
Yes.
Do you agree?
Dr. Hassan, yeah, I totally agree. But the point is, the posterior tunnel will prevent anterior migration, but it will not prevent posterior migration, because I still believe that the valve, when you dissect everything nicely, and then you put the valve could slip posterior if there is enough space, so that the sutures will prevent the posterior slippage of the tube of the valve.
Another important point is also while creating the scleral tunnels. I did this technique. I learned from you. I did some modification without creating flap. I did 3 tunnels, go directly to the anterior chamber. But I found that when you make a narrow tunnel, it will be much better than wide tunnel. Narrow entrance, it's just you can insert the tube through the tunnel. That will prevent the horizontal movement of the tube, and that will, I think, it will be better for the erosion by the time, to be less erosion when you decrease the horizontal movement of the tube while you make narrow tunnels. I don't know if do you agree about this point or not.
So you have the mind of an engineer. You have the mind of an engineer. Look, yes, always, that always we question what we are doing. That's very normal, and that's the secrets behind the improvements. So that when you do when you do first tunnel and second tunnel, so that you can think of the articulation of the whole tunnels, how they interact with each other. It is not just a single tunnel. So that the 3 tunnels, how they will interact, especially if we would have a fixed entry of the tube. A lot of geometry at this point, which I really beyond my brain to imagine and calculate. But definitely, you are questioning everything, which is the nature behind any improvement. Yeah, thank you, Hassan.
But Dr. Ahmed, as engineers, this is not agree. Sorry, Dr. Abaida, but only this as engineers, we not agree with this point only, because it's so much tunnel. It's difficult to take the tube 1 point. On second point, this is the curve, the sclera more over the tube. And for that, this is the same technique, but I make 1 tunnel from anterior to posterior from long time. I make, and this is only the 1.5 for the crescent on go posteriorly. If this is the tunnel, you didn't need so much wide and you didn't so much cross, because you need the over the tube, the sclera to go smoothly to the side. If you make so small, this is the sclera cover directly over the tube and may make the tube is more prominent under the sclera. And in this type, we will more risk for exposure. If you have more smoothly, that's the risk for exposure, I think, will be less. Sorry, Dr. Abaid. Yeah, please, Dr. Abaid.
Dr. Ali, I mean 3 tunnels, not 1 tunnel.
Dr. Hassan, let's Dr. Abaida. He has raised his hand since 1 hour.
Assalamu alaikum wa rahmatullahi wa barakatuh.
Alaikum assalam wa rahmatullahi wa barakatuh.
All panelists, to be honest, it's a pleasure joining you here. It seems like all of the nuggets from the talk are being discussed here. It's beautiful to hear this discussion, because you've got a cumulative experience of decades, mashallah, here about aqueous shunt surgery. I just wanted to make a few points for discussion. Obviously, right at the beginning, we discussed needling for tube shunts. I completely agree with you, Professor Ahmed, that if the way in which the capsule forms around the aqueous shunts, around even micro shunts and Pressiflows, I've put nearly 300 Pressiflow micro shunts in now, is quite similar to each other. Actually, you get an encapsulation which is very different to the sort of the healing that you get around trabeculectomy blebs. So definitely, if I start to see that a aqueous shunt is starting to fail and they're heading towards 3-4 drops, and I'm still at suboptimal intraocular pressure, I primarily use Barvelt tubes. I've put in a few Pulse tubes as well, but my go-to is Barvelt, because I usually have a little bit more control at the moment, and I have a lot more experience with Barvelts. I usually go for revision. It wouldn't be towards a needling. And in pseudophakic eyes, one of the great tools that I also use is Vision Blue. So intracameral Vision Blue I use quite well. It highlights to you if there is flow, where there is flow, of course, in the absence of any incarceration of the iris at the entry into the anterior chamber. So that's the first point I wanted to make. The second point I wanted to make is the Pulse tube, I think, is something that's really, really going to be interesting, because risk of hypotony is going to be reduced significantly. One of the biggest problems that we have with the PRESERFLO works. It's 70 microns, it works, but it doesn't work in everybody, especially in Black Afro-Caribbean young patients with multiple co-pathology. It doesn't work. They encapsulate early, they scar early, and they end up failing. And I end up putting a Barvelt or a Pulse in them. And the presence of a plate creates a little pool for the capsule to form, a little reservoir of aqueous to drain in the subconjunctival space. And I think in those patients, it's a good fallback to have on. I've had a few PRESERFLOs fail now that I've actually put Barvelts in. And in Barvelts, similar to ClearPath, you have the problem of early control. So in these patients, I put in the intraluminal 3-O-proline, previously Supramid, and bury it in the inferior fornix with the addition of 2 ligating sutures and a distal vicryl, a proximal vicryl, and a distal proline, 8-O-proline or 7-O-proline. And this usually works quite well. But I put my PRESERFLO similar to you, Professor Mustafa. Any tubes in the eye, I tend to keep them as posterior as possible, whether they're phakic or pseudophakic, because I don't want the headache of having to refer to the corneal surgeons, as accommodating as they are, Professor Sinjab, in doing DMEX and DSEX. But I've tended to keep the PRESERFLO in. I haven't put Sherwood slits in, and it achieves the early control for early 6 to 8 weeks. After revising the PRESERFLO, the subconjunctival space is a little bit deranged, but it's not as deranged as you would expect, for example, in a tube revision or a trabeculectomy revision. So those are the points I wanted to make. The Pulse tube is very, very interesting. It's only 127 microns inside the lumen. And one of the newest techniques that I've seen, I haven't done this yet myself in my practice, is actually instead of like we would do with a Barvelt, for example, and put an intraluminal Supramid or 3-O-proline and put it all the way down into the inferior fornix under lateral rectus, we would just do it as we would do a releasable in a trabeculectomy, because you're only putting an 8-O-proline inside. And much like a releasable in trabeculectomy, you keep a short end that you take out and you pull through at 6 to 8 weeks. So this is really quite interesting, you know, they not needing to take the patient back to theater. Obviously, the risk of hypotony in these patients is much less compared to Barvelts. And that's what I wanted to say, really. It's been fascinating to hear. Oh, the last thing, sorry, I wanted to say was, in my practice, I tend to do a tutoplast, pericardial tutoplast, to prevent extrusion of the tube. And as Dr. Ali Sheikh has said, it is at the kink where you tend to get in my experience, where you tend to get the where you tend to get the extrusions and the exposures, and it's where your entry. And although the dragon technique that Professor Mustafa has described, and his multiple dragon techniques, sort of, where I mean going in and out, it does reduce the risk of that. The tutoplast is also a good alternative for those who find it maybe in your hands, Professor Mustafa. It's quick to do that, but you know, fashioning a partial thickness scleral flap may take a little bit longer than tutoplast if you glue it down. And also, I was wondering about your refractive considerations when doing this. Do you think it reduces the mechanical integrity of the sclera in your experience by sort of tenting the globe in a more vertical fashion, and hence causing sort of with the rule astigmatism? Those are the kind of things that
I have, yes. I think that unfortunately most of our patients are having a kind of advanced glaucoma, and then some refractive considerations, they come, you know, at the end of the list. So that with one-eyed advanced damage, yes, they could get some astigmatism, but this is not the problem. But I have some questions for you. Thank you very much for your nice contributions. Actually, I'm happy that you are doing Barvald, because that's the other arm of the story. That's the other side of the coin. But I just want to ask you, why do you think the new medical world have introduced the clear path to the market? Because it's a kind of, are they mimicking the Barvald, and are there obvious advantages of the obvious advantages of the clear path to Barvald, because clear path is not as small as we imagine. It's 250 and 350 square millimeters, still a big one, but might be amputated. The posterior part is a kind of the different shape. But again, my first question was that why do you think they have introduced the non-valved implants to the market, and they are they're a kind of or they want to have all the items in the menu, whether valved or non-valved? This is one question. The second question, that you mentioned the pressure flow many times, that do you think the pressure flow in the same category like the glaucoma drainage implants, or it's a kind of it's done as a primary procedure, and what we are talking about they come next? So that are they in the same, that the same bag or same basket? Or
fantastic. Two very pertinent questions. I'll answer your second one first. In my treatment ladder, Sulam al-Ilaj, I tend to leave my tube shunts right towards the end, because I know that a pressure flow won't work in everyone. I know it works well in 70-year-old white ladies. I know it works well in patients who are old and Afro-Caribbean, but young pro-fibrotic patients with a high VEGF drive, even if I give them intraoperative Eylea or even Eylea a week before, they still have very, very vascular angry blebs. And I tend to inject these blebs with 5FU, even at week 1 and week 3. Despite that, you'll find they may work for a period of 4 to 6 months, but then you're just adding up medication, and then they fail. So patient selection, much like our earlier discussion about refractive surgery, I think is so imperative in pressure flow. As I said, patient selection is really, really important. And only in patients, say for example, I have a rubiotic coming in that is regressing, but nevertheless they've still got blood vessels, I would not put a pressure flow in. I did about 7 rubiotics with pressure flows during the time of COVID, when we weren't really seeing patients, and the diabetic retinopathy screening program was going down, and so we were seeing a lot of rubiotics at that time. We're going to be publishing a paper soon about the trends in rubiotic glaucoma, and what I found is that yes, we were buying time by putting pressure flows in, but most of these, yes, some of them have worked on they're on treatment with a pressure within target, but had we reversed time and put in a proper Barvald tube, we would probably not need to take them into theater again, or do a diode, or do a specific protocol diode for these patients. As you know, in the UK, we've stopped doing micropulse for nice purposes, from a nice perspective. So pressure flow has its place, but I still always said, I mentioned in the talk a couple of days ago, that trabeculectomy remains the gold standard in patients who do not have a strong pro-angiogenic drive, and tube shunts are the ones that I would use in patients who have failed trabeculectomies, rubiotics. Interestingly, uveitis, pressure flow works beautifully in uveitis, the most beautiful blebs you will see, particularly with a concomitant Eylea or Avastin or whatever anti-VEGF you like. It works beautifully, and I give subconj cefuroxime and dexamethasone in all of these patients, trabs, tubes, and pressure flows, any subconj surgery. The second part of your question, I hope that answers your first question. The second part of your question is, why is New World Medical coming up with the clear path? Well, I think that the Western barbell, the barbell market is largely dominated by the West. In the Middle East and the EMEA region, the Middle East and Northern Africa region is largely dominated by Ahmed glaucoma valve. And a lot of key opinion leaders like yourselves will stand up and say, oh, the barbell is fantastic. You have good control. It achieves lower pressures in the long run. You know, but you have more control by doing argon suture lysis. You have lower, you know, you can remove the supramid, and at some point, so you have more control over the pressure that you're going to achieve. And New World Medical does not have an answer to that. They've just got the Ahmed glaucoma valve, so that's a target market. So from a corporate perspective, I think they have tried to put something on the table that is competitive. The second reason as well, the ClearPath is smaller than the barbell. It's much smaller and actually easier to use. No slinging muscles, none of this business at all. So that's their selling point. Every device that goes in, as you know, takes millions and millions in order to have in terms of research and development. And so they're trying to justify a new device that's a little bit better. One contains a valve and one doesn't. So they try and take over the entire market, because not many people in the Middle East, to my understanding, put barbells in or poles. It's all dominated by AGVs and the ClearPath, it seems, in more recent times. Hope that answers the question.
It's perfect. And you know, also there is no valve mechanism, so it's thinner. So the ClearPath is definitely, though the surface area might be larger than the Ahmed glaucoma valve, glaucoma 180 something, but it is no valve. It's just more, you can manipulate easily. Thank you, Obaida. Thank you for the contribution.
And the last thing I wanted to say is it must be 3 years since I've put in 2 eye watches, and I don't really, and I've managed them post-operatively as well. I don't really see myself, I don't see much added value in the iWatch. It's a very bulky, big device. Their argument is it has a role in patients who are very, very much at risk of post-operative hypotony, young myopic patients, as we discussed earlier, who've got very, very thin sclera, who will become hypotenuse in conventional tube surgery. My humble opinion is that I don't think the principle of it works, because the restriction is not at the lumen. Your restriction is forming the capsule, number one. Once the capsule is formed, yes, you can have control by removing the intraluminal suture gradually, partially, or whatever it is. But I don't think dialing it with the magnet is the answer. And sometimes the magnet does get stuck as well. So it's not the answer to everything. And in principle, it sounds amazing. You have a little magnet. You don't need to go do argon. You don't need to remove sutures. Completely aseptic technique. So on paper, it's a nice engineering mechanism, novel way to come up with. But in practice, it's actually, the surgery takes much, much longer, probably around 2.5 to 3 hours, even in the slickest of hands. So you could probably do around two barbells easily in that time, if not more, in your very expert hands. So in my humble opinion, I think it's a bit of an expensive device that has very, very limited role in at least in my practice.
Yeah, interesting. And it's considered as what MIGS?
No.
What is the classification?
The pressure flow is the pressure flow. The pressure flow, I would say, they call it a micro shunt from a selling perspective, purely because the smallest shunt available is 127 microns, which is a Paul's tube, and the barbells are running around 300, similar to the Ahmed. But the 70 microns in the pressure flow, yes, but you still are doing it ab external. So you're still doing a peritomy from the outside. So they try to sell it as a MIGS, but in actual fact, I would call it a supra MIGS, where it's like MIGS plus. It's not quite full trabeculectomy surgery. It takes me 20 minutes, 25 minutes at most if I'm having to put an extra 2 conjunctival sutures. But it works fantastic. When pressure flow works, it's an absolute dream. No matter, regardless of what the preoperative intraocular pressure is, you will expect at day 1 your pressure will be between 5 to 7, and at 2 months your pressure will be 12 to 14, and it stays like this.
That's interesting, and I think it should be compared to Zen gel implant, for example. They are more or less of a kind of in this area, or they are all together, and we can think which is more superior. In some cases, like the uveitic glaucomas, you really surprised me by that, because uveitic glaucomas, they tend to respond beautifully to different surgeries, like the valves, they respond to angle surgery, they respond hemigag, they respond something very strange, and sometimes they do not respond immediately, but after a while you get a perfect response. So those eyes, they need a bit of more focus. They respond beautifully to most of the surgical procedures. Yes.
Thank you for so much for letting me contribute amongst
you
guys.
No. That was very nice, really. That was very nice.
جزاكم الله خيرا جميعا. Thank you very much, everybody, and it was a very interesting session. So I think we have only 2 questions to go through. The first one, do you do tube flushing if the IOP elevated? Dr. Ahmed?
So that I think tube flushing is not an easy procedure. You need to go into the OR. It's not a slit lamp procedure, and then you have to have a good control of the intraocular management. And then if you're going to push fluid, and then just think and what? And then what if you're going to push fluid? It looks like massage, so that you can replace this with a kind of digital massage. You don't have to flush. I did it once, and I actually didn't find any response, but the pressure was really high, so that it doesn't do anything additionally, or not injecting like anti-metabolite. But the digital massage, I think, will do the work. And at the end of the day, it's not an easy procedure to flush, unless you are having like hyphema. You need to give tissue plasminogen activator, something to the story. But just to flush fluid, no, I don't advise.
Can I make one, Dr.
Yes.
Mazen? Only
yes,
the tube flushing, if this is, you have a very go back, that's the blade posteriorly on the tube is go outside the eye. Can you open the tube only anteriorly? And can you try with the flushing? This is the benefit of the flushing. If you make the flushing and find very good outflow, and this, can you make this tube extender? You didn't need to remove the blade on all the blade, only cut the tube and put the tube extender inside the eye, or the modification that presented from Dr. Ahmed also with, as a small sleeve, or the tube extender from the company. In this case, the tube flushing is good, not to remove all the blood and make a new operation. Sometimes you find the blade is working very well behind, only the pressure is go up because the blade go posteriorly on the tube, go from the eye on the close with the sclera. This is the benefit from
that's why we apply non-absorbable sutures, so that the plate doesn't.
I agree with you.
Yeah. Now the other question is, what about Paul glaucoma valve?
I think you have mentioned this. Bowles valve, you have mentioned Ali and Ubaida.
Yeah,
I've talked about this. Yes.
All right. So that's it. And thank you very much for Professor Ahmed Mustafa for the very fruitful and full of science presentation as usual. I love your way in presentation because it's very simple and direct to the point, very easy to understand even for non-glaucoma specialists. And thanks for all the panelists who very, very kindly contributed to the very nice discussion and added a lot. And thanks for all the audience who stayed with us. And see you next week, inshallah, same time. Assalamu alaikum wa rahmatullahi wa barakatuh.
Dr. Mazen, before you go, just next week, I'll bring some challenging cases. We will have different opinions, I think, so that we can have different points of view. please come. And I'll try my best to bring interesting cases, inshallah. Thank you very, very much.
Inshallah. So there will be a button.
Thank you very, very much. Assalamu alaikum wa rahmatullahi wa barakatuh.
Bye bye.
Bye bye.